Assalamu alaikum, it's me Dr. Naseem Shirzad, and today I'm going to discuss with you all prone belly syndrome. Prone belly syndrome, the word prone means dry alucha, means the khushk alucha. So when the khushk alucha, the abdomen of the prone belly patient is just like when the alucha get dry. So it's the name derived from that khushk alucha. So, uh, this Prone-Belly syndrome is also known as triad syndrome, eagle-barrett syndrome, and abdominal musculation syndrome. So, this is Prone-Belly syndrome is known by these three names also. And the epidemiology of this, that its incidence is around to 1 in 40,000 live birth, and its 95% occur in males. The higher incidence is present in the twins, blacks, and children born to a younger mother, and the incidence in twin is discordant. Now it's asking that what's the genetic of Prone Belly syndrome? The genetic of Prone Belly syndrome is that it having a normal karyotype, and the normal karyotype is the rule for Prone Belly syndrome, but it is associated with other syndrome like Turner syndrome, Purtu syndrome, which is trisomy 13, Edwards syndrome, and Beckwith-Weiderman syndrome. So it's associated with this syndrome also. Now coming to the major finding of Prone Belly syndrome, there are three major triad or finding of Prone Belly syndrome, which include abdominal musculature deficiency, bilateral intra-abdominal testes, and abnormal urinary tract, or we called it anomalous urinary tract. So these are the three main feature by which is also called triad syndrome. Now coming to the word pseudoprone, what is meant by the word pseudoprone? When the prone belly syndrome present in female, we call it pseudoprone, or when it is present in male but they don't have the complete triad of prone belly syndrome. Hence, a male with a lax abdominal wall but without undescending testes or without a dilated urinary tract, and all females are considered a pseudoprone. So this is the concept of pseudoprone. Prone belly syndrome in female is called pseudoprone, and when in male present the triad is not complete, like the patient will be having lax abdominal wall but the patient will not be having undescending testes or without dilated urinary tract. Now what are the differential of diagnosis of Prone Belly syndrome? Amniotic band syndrome, vasculomegaly, posterior valves, polycystic kidney disease, impaired lymphatic drainage and Turner syndrome, and giant liver cyst. So these are the various differential diagnoses of Prone Belly syndrome. Now coming to the pathogenesis, and or we call it the various theories regarding the Prone Belly syndrome. There are mainly four theories regarding Prone Belly syndrome. The first theory says that early in utero posterior urethra obstruction resulting in severe dilatation of urinary tract and possible fetal ascites and oligohydramnias. The second theory saying that there is actually a primary defect in the lateral plate mesoderm which giving these various structure like the bladders. And the third theory is saying that there is actually intrinsic defect of the urinary tract and that leading to urethral dilatation. And the last theory, that is the yolk sac defect theory, they are saying that there is an intrinsic defect in the yolk sac. So these are the four theories regarding the pathogenesis of Prone Belly syndrome. Now coming to the various manifestation and the obstruction caused by these Prone Belly syndrome. Number first, coming to the that of the kidney. In 50% of patients there is actually renal dysplasia, and there is obstruction, but that is non-obstructive hydronephrosis, and that is the rule. And there is presence of Porter type 1 and type 4 varieties are present. Actually, there are four types of Porter. Porter type 1 is autosomal recessive dominant, autosomal recessive polycystic kidney disease. Type 2 is actually renal dysplasia. Type 3 is that of autosomal dominant polycystic kidney disease. And type 4 is urethral obstruction leading to dilatation of the upper urinary tract. So in Prone belly syndrome, actually type 2 renal dysplasia and type 4 in which there is urethral obstruction, these two type porter are present in Prone belly syndrome. And maybe there is ureteropelvic junction obstruction which may be secondary or primary. What about ureter? There is a dilated, tortuous, and redundant ureter, and we are present in 75% of these children. And the ratio of collagen to smooth muscle is elevated in refluxing ureter, and there is a massive dilatation and stenosis can occur at all level. So this is the ureter presentation. Dilated ureter, ineffective peristalsis, stasis, and leading to infection. Now, what about bladder? The bladder will be enlarged with pseudodiverticulum at the urachus, and patent urachus is present in 25 to 30% patient, and the ratio of collagen to smooth muscle is increased without any obstruction, and the bladder is enlarged bladder, and there is a smooth muscle hypertrophy seen in obstructed Prone belly syndrome. So this was all about the kidney presentation, the ureter presentation, and that of the bladder. Now coming to the prostatic anomalies, there is a dilated posterior urethra, obstructive lesion may be seen, and there is a type 4 valve angulation of the urethra during voiding. But again, the urethral anomalies are important. There may be urethral atresia, hypoplasia, or there may be presence of megalourethra. Megalourethra may be of two types. One is scaphoid variety and the other is called fusiform variety. In scaphoid variety means there is a single deficiency, or we can say there is a deficiency of spongiosum only. And the other is the fusiform variety in which there is a deficiency of spongiosum and cavernosum. That's why in a patient with fusiform variety, when the patient is voiding, there is a complete dilatation of the pelvis, while in scaphoid, when the patient is voiding, there is only dilatation of the ventral part of the pelvis. So in fusiform, there is a complete dilatation of the pelvis, while in scaphoid, there is only the ventral dilatation during voiding. So megalourethra, a newborn with Prone belly syndrome with evidence of megalourethra, and there may be a penoscrotal transposition. Now coming to the third part of the triad, and that is the abdominal wall defect. Medial and inferior muscle segment are typically involved. The order of severity of involvement from most to least involved is transversalis abdominis is the most commonly involved. This is the least involved. Then the rectus abdominis is the most common. Then internal oblique. Then external oblique. And then rectus abdominal muscle above the umbilicus. So this is actually the range of severity from most to least. So commonest involved is transversus abdominis, followed by rectus abdominis, followed by internal oblique, external oblique, and rectus abdominis. So this was about the abdominal wall, and most severely affected area may have skin, subcutaneous fat, and poor support of lower chest wall, leading patient will be unable to cough, and the patient much of the time having constipation. And what about the extragenitative urinary abnormality? Cardiopulmonary issue present in 49% of patients, while orthopedic 65%, and GI problem present in 65%. So the next common is the gastrointestinal, that is 65% of patient having this problem. The orthopedic problem may be the patient having pectus excavatum scoliosis. The second component, that was the cryptorchidism or bilateral intra-abdominal testes that is lying over the iliac vessel and adjacent to the dilated ureter, and these are the most typical finding. And some other found no difference in germ cell count, spermatogonia, and Leydig cell between Prone belly syndrome testes and non-Prone belly syndrome intra-abdominal testes, and others saying that there is a decreased in number. So this was about the testes or bilateral intra-abdominal test. Now coming to the diagnosis of the Prune belly syndrome, the prenatal diagnosis, actually the Prune belly syndrome is most commonly diagnosed during the second trimester, and ultrasound is similar to other causes of the congenital bladder outlet obstruction. Disease can be diagnosis can be made as early as 11 to 14 week, and clinical finding will be include there will be hydronephrosis in the kidney, there will be distended bladder and irregular abdominal wall. So it most commonly diagnosed during the second trimester, and the neonatal presentation is that like appearance of the abdominal wall immediately suggests the diagnosis of Prune belly syndrome. Cardiac and pulmonary abnormality take precedence over urogenital abnormality in the absence of true bladder outlet obstruction, and it has been divided into three main categories, which is called the Woodard classification. So the Woodard classification categorizes it into three main categories. Number first, category 1, 2, and 3. Category 1 can be remembered by formula ROUP, R-O-U-P, ROUP. ROUP mean R mean renal dysplasia, O mean oligohydramnia, U mean urethral atresia, and Phi mean pulmonary hypoplasia and Porter features. This is one of the severe form of Prune belly syndrome, and much of the patient come to die in first few days of life. The second is the full triad features. There is a full presence of triad, and there is minimal or unilateral renal dysplasia. There is no pulmonary hypoplasia, and this patient may progress to renal failure as the patient is having minimal or unilateral renal dysplasia. The third is the category third is the most stable one. There is incomplete or mild triad features, and there is mild to moderate uropathy. There is no renal dysplasia, stable renal function, no pulmonary hypoplasia. So this is the one in which there is the patient is remain stable. And now we come to the management of this Prune belly syndrome. So this is a multidisciplinary multidisciplinary evaluation. Like there is a need of neonatologist, there is a need of nephrologist, there is a need of urologist, there is a need of cardiologist and orthopedic surgeon, pediatric orthopedic surgeon. So the initial evaluation, that is ultrasound, serum creatinine and electrolyte level to rule out systemic acidosis and electrolyte imbalance, and the baseline creatinine of less than 0.7 milligram per deciliter, showing that there is adequate renal function. In the presence of renal insufficiency, VCM MCUG is warranted. And the management, like for category 1, the prognosis is bad. Most succumb to the disease in the newborn period. Only supportive care is needed, and simple bladder drainage is advisable. And category 2, the treatment is individualized on the basis of evaluation. An evaluation of the renal function and drainage is required, and IVU provide dramatic images. And for category 2 evaluation include parenchymal function like DMSA at 4 to 6 week of age, renal outflow obstruction. For exclusion of renal outflow obstruction, go for MAC3 scan. In case of poor renal function, selective use of whittaker can also be advised. And for the treatment of category 2, aggressive intervention is recommended. Infection and progressive renal insufficiency, so greatest threat to quality of life. So it's better to address the disease aggressively and can be combined with circumcision, archaeopexy and abdominoplasty. For category 3, actually we know that there is a good renal function, so rarely require early urological intervention, regular monitoring of urinary tract dilatation using ultrasound, regular monitoring the patient for UTI, correct cryptorchidism at 6 months or 1 year of life. Abdominoplasty may be needed if the patient having cosmetic problem, or the patient is having problem in cup, or the patient is having constipation. So abdominoplasty may be required in category 3. Now we have already discussed the three main triad, that is the undescended testes, abdominal wall, legs abdominal wall, and the urinary tract dilatation. So we can go for urinary tract procedure, archaeopexy and abdominal wall reconstruction. So we can address one by one all these procedure. Like urinary tract procedure, we can go for if the patient is high grade VOR or recurrent infection, so we can consider the patient for reconstruction like vesicostomy, or there is a place of ureterostomy. And now coming to the archaeopexy, transabdominal bilateral archaeopexy at 6 months of age is the approach of choice. It can be done in conjunction with abdominal surgery. And for undescended abdominal wall reconstruction, if the patient having moderate to severe degree of abdominal wall laxity, and that can be done as early as 6 months of age, can be combined with archaeopexy, and that's improve the osmosis and the bladder, bowel and pulmonary function in these patients. And the various technique for the abdominal procedure that can include Rendolep techniques, Ehrlich technique, Monfort technique, Danish techniques, and Pornis techniques. So these are the various techniques that can be done for the abdominal wall. So this was all the detail about the Prune Belly syndrome, from pathogenesis up to the treatment.